Okay, so today we're going to do coronary artery disease. We're going to we're going to define what coronary artery disease is, look at the normal coronary artery anatomy, clinical presentation for CAD, the risk factors for CAD, how you make the echo diagnosis. We're going to use this opportunity to define and go over myocardial performance index, MPI. We're also going to look at DPDT, assessment of ventricular contractility, and then we're going to close with mechanical complications of coronary artery disease. All right, so when we say coronary artery disease, what are we talking about? So you know you have a number of blood vessels around the heart, on the surface of the heart. And if you remember your anatomy, on the left side, you have what we call the left main coronary artery disease. And the left main coronary artery disease splits to give you a left anterior descending coronary artery and a left circumflex. And those blood vessels are going to have branches. And then on the right side, you have the right coronary artery, and that gives branches as well. So just looking at the blood vessels around the heart itself, the left main, which comes down like that, which is on the left side, okay, you're going to have the left main is going to give a branch. We call that the left anterior descending coronary artery. And then it's going to have one that loops around the back of the heart. And we call this the left circumflex. Sorry, the drawing is horrible. But anyway, this is the left main. Okay, the left main coronary artery. And then this would be the left anterior descending coronary artery. And then this is the left circumflex. Okay, so this is on the left side, the left main, the left anterior descending coronary artery, the left circumflex. And then on the right side, you have the right coronary artery. Right coronary artery. So this is, oh God, this is the RCA. So the pen, so this is supposed to be a hard sign. This pen doesn't want to work today. So it's the right coronary artery, RCA. Okay, so these blood vessels should be tubes, all the tubes that have no obstruction in the lumen. But if you have risk factors and the conditions are right, then you'll have the buildup of plaques in these blood vessels. And these plaques can grow until they obstruct blood flow in the blood vessel. So you can have a gradual buildup of the plaque, and you can have gradual obstruction to the blood flow. Or if the plaque gets to a certain size, the plaque can burst. When the plaque bursts, bursts, then you have blood clot on top of the plaque. When the plaque ruptures, blood quickly clots on top of that and acutely close off the blood vessels, and that can give you clinical symptoms. So when you have the buildup of plaque in the blood vessel, we call them the epicardial blood vessels. Same thing as coronary artery. Then you can get narrowing, which results in reduced blood flow. Again, it can be a gradual process if you have gradual buildup of plaque, but it can also be an acute process, and that's what we say someone have a heart attack or an acute myocardial infarction. That's because the plaque ruptures and blood quickly clots on top of that and acutely block the blood vessels. All right, so that's so those are the two acute scenarios. All right, so again, the left main coronary artery is right there. This is the left circumflex, and the left anterior descending coronary artery is right there. Let me just erase this. And then the right coronary artery is right there. And these three main blood vessels give branches. Again, the left main coronary artery comes from the left coronary cusp or left coronary sinus, and the right coronary artery comes from the right coronary sinus or cusp. Okay. All right. So just looking at the left circumflex, which loops around the back of the heart. So this is what when the normal blood vessel is supposed to be smooth, no obstruction in the wall. Okay, so it's supposed to be a nice, smooth blood vessels. But when you develop plaque, this is what we call atheromatous plaque. So the buildup of plaque in the wall, which limit the blood flow. So if you were to look at the cross section, so if you were to cut the blood vessel in a cross-sectional pattern, the normal blood vessel will look like this. Okay, the inner portion is what we call the endothelium, and then just beyond the endothelium is the muscular layer, and then outside of the muscular layer is we call that the adventitia. So when you have a plaque buildup, so you'll develop plaques if you have risk factors and the conditions are just right, and the plaque can be obstructing. So this is what the plaque looks like in a cross-sectional cut. But this plaque can burst, this plaque can rupture. And if the plaque ruptures, then you can get acute closure of the blood vessels. And that's what gives you a heart attack. Okay? So how do these patients present? So it might just be an incidental finding. Patient go to the echo lab, they may have reduced ejection fraction, or they may have a segmental warm motion abnormality, and you do further tests and you find out that they have blockage, or they can present with a myocardial infarction, which is a heart attack. So myocardial infarction is the same thing as a heart attack. So that's when the plaque ruptures and you have the blood clot on top of that acutely, and there's no blood flow to the heart muscle dies, and that's what we call a myocardial infarction. Myocardial because it's the heart muscle. Infarction is when something dies. Okay, when something dies, we say it's infarcted. Or if you just have obstruction to the blood flow in the blood vessel, because the heart muscle is not getting sufficient blood, they can present with angina, and the angina can be unstable or it can be stable. when we say that the angina is unstable, what we're saying is it's either new onset. So when someone have angina for the first time, we say it's unstable angina. Or if they have stable angina, say they normally get chest pain when they walk 10 blocks, and now they're getting chest pain when they walk 1 block. Or if the chest pain is lasting longer, uh, occurring more frequent, then that's what we call unstable angina. Or some patients, their first presentation is sudden cardiac death. That is, they have a heart attack and they go into ventricular tachycardia, ventricular fibrillation, and dies. Okay, or just the obstruction itself, because there's decreased blood flow to the heart muscle, then the heart becomes very irritable and they can develop ventricular tachycardia, ventricular fibrillation, or heart failure. So if you have significant occlusion of the blood vessels around the heart, it can weaken the heart muscle and they can develop systolic heart failure. Or if you have blockage, it can also develop diastolic heart failure because the heart does not relax properly and can become stiff. So these are the different type of presentation for someone with coronary artery disease. So risk factor, you have to know the risk factors for coronary artery disease. These are the things that if you have them and you have enough of them, your chance of getting coronary artery disease is going to be great. So age. So the older one gets, the more likely they'll get a heart attack. Smoking is a very potent risk factor for coronary artery disease. Dyslipidemia, so it's either a high, if you have a high LDL level, low density lipoprotein, or a low HDL. So that is why I would say dyslipidemia. So abnormal cholesterol, hypertension is another strong risk factors, diabetes mellitus, obesity, and family history. So these are the risk factors for coronary artery disease. If you have these conditions and you have enough of them, your chance of developing blockage or coronary artery disease is going to be great. So how do you risk assess someone with coronary artery disease? When we say risk assessment is, someone have a blockage, you need to tell them, well, your chance of getting a heart attack in 5 years is X, or your chance of getting a heart attack in 10 years is X. So you can risk assess the patients when you see them. And we use the Framingham score. So Framingham is an area in Massachusetts that they did a lot of study. They did a population study, and from that study we can extrapolate and talk about the burden of certain disease in communities. So when you risk stratify your patient, you're going to take into account the age of the patient, the total cholesterol level, the HDL cholesterol level. So remember, total cholesterol, you're going to look at both the bad and the good cholesterol. The bad cholesterol is called LDL, the good cholesterol is HDL. You want to have a low LDL and a high HDL. So you also look at the smoking, systolic blood pressure, and diabetes. So the Framingham risk score take these things into account and give you your risk of developing a heart attack in 5 to 10 years. But we're here to discuss echo. So how do we use echo to make the diagnosis of coronary artery disease? So we can do resting echo and we can do stress echo. When you do a resting echo, resting to the echo, things that are going to tip you off that this patient have a coronary artery disease or a blockage is if you see wall motion abnormality. Remember, when you look at the heart, you divide the heart into segments. Remember your segments. So if you see a segment that is not moving very well, and remember you have to use your motion score. We say a normal thickening, normal motion score of 1. If it's hypokinetic, score of 2. If it's akinetic, score of 3. And then if it's dyskinetic, score of 4. So you have to put these things now into your assessment. Okay, so you're going to look at the wall, and if the wall have good motion and thickening, then it's okay. If it's hypokinetic, it could mean that there is decreased blood flow to that area, causing that area to become either hypokinetic, akinetic, or dyskinetic. So wall motion abnormality is a tip-off. Ejection fraction also is very important, because if you have significant blood vessel occlusion, if you have enough blood vessel being blocked, then the ejection fraction will be reduced. How well the heart is pumping will be affected, and the ejection fraction may be 20%, 30%. So one of the more common cause for a reduced ejection fraction is blockage, coronary artery disease. So again, they 2D echo may show evidence of reduced ejection fraction. You can also the heart wall may be normal. So you need a certain amount of blockage before the resting motion is affected. But not only that, at rest, because you're not, the heart muscle doesn't require a tremendous amount of blood flow. The walls may look normal at rest, but when you stress the patient, then because you're not getting sufficient blood flow to the heart muscle doesn't move very well. And we use that when we're doing stress tests. So at rest, because the heart muscle doesn't require a tremendous amount of blood flow, everything moves well. But once you exercise the patient and the heart muscle now demands more blood flow and you can't deliver, then it becomes either hypokinetic, akinetic, or dyskinetic. Another important presentation with someone with coronary artery disease is they can present with diastolic dysfunction. And we just finished diastolic dysfunction lecture looking at what is classified as diastolic function, how we define diastolic function, and the grading of diastolic dysfunction. Coming out of all of that is what we call diastolic stress test. So the diastolic stress test is important because some patients who have blockage, all they have is exercise or exertional shortness of breath. So once they're at rest, they're okay. But when they start doing any type of activity, they get shortness of breath. And one of the rationale for that is diastolic dysfunction, because what happened at rest, they would have usually a grade 1 diastolic dysfunction. With a grade 1 diastolic dysfunction, I've been teaching you guys, a grade 1 diastolic dysfunction, the E prime is going to be reduced, the left atrial volume is going to be normal, the PA pressure is going to be normal, So, that's your grade 1 diastolic dysfunction. But once the patient starts to exert themselves, the diastolic dysfunction gets worse. And if the diastolic dysfunction gets worse, then what's going to happen? Your EE prime ratio is going to go up. The PA pressure is going to go up, and the patient is going to have shortness of breath. So we can use that fact to do a diastolic stress test and show that the patient have worsening diastolic dysfunction with exertion. Okay, we'll go over that. But so this is a patient with a reduced ejection fraction. Okay, so this would be, again, one of the most common cause for a reduced ejection fraction is coronary artery disease. Okay, so right away you would think coronary artery disease, blockage. But when you see a patient like this ejection fraction is pretty low. So more than likely there are multiple blood vessels that are occluded. Okay, you can see, especially the apex. The apex is probably akinetic, but the whole thing is hypokinetic. So coronary artery disease is one of the most common cause for this. Again, you can see there's a tiny E, a fairly big A. So, this patient, we can grade the amount of diastolic dysfunction. So, and then your two-chamber view, you can say the inferior wall is hypokinetic, the anterior wall is hypokinetic as well, but the apex is probably akinetic. So your resting 2D echo can give you a tip-off, especially if you see regional or segmental wall motion abnormality. Okay? Now, stress test is one of the echo tools we use to diagnose coronary artery disease. When you do a stress echo, you're going to, essentially what you're doing is a stress ECG and a stress echo combined, and you're going to put them together and determine the likelihood that this patient have a blockage. Okay? We can use, when we do stress echo, we can exercise the patient, where we use the treadmill or the bicycle, or you can do a dobutamine stress echo. So you can do a treadmill stress test, or you can do the bicycle. It's a supine bicycle. So the patient lie on their back and they're hold on, and they hold on to the steering and they're pedaling. Okay. Most of what we do is a treadmill stress echo. You can also do dobutamine stress echo. So if the patient cannot exercise for whatever reason, or if the patient is taking medications that will affect how much they exercise, you can do the dobutamine stress echo. All right, so again, let's revise the coronary artery territories. That is, you have to know which blood vessel is supplying the different areas of the heart muscle. Because once you know that, when you develop wall motion abnormality, you can correctly predict which blood vessel is going to be occluded. So if we can just recap, because this is something we have done before. So this is the short axis at the basal level. So it's short axis at the basal level. When we say the basal level, that's at the level of the mitral valve. Again, this is the anterior wall. The inferior wall is there, lateral wall there, and the septum. So this will be your anterior septum, inferior, sorry, anterior lateral wall, inferior lateral wall, inferior wall is your inferior septum, and your anterior septum. And these are you can see the blood vessels that supply these areas. So at the basal level, the anterior wall is supplied almost exclusively by the LAD, the left anterior descending coronary artery. So the anterior wall and the anterior septum. And then when we talk about the inferior septum and the inferior wall, almost exclusively by the right coronary artery. And then the lateral wall, the anterior lateral wall, and the inferior lateral wall by the left circumflex. Okay, so you need to memorize this, okay, because you will need to use it at some point in time. So the anterior wall, the anterior septum, LAD, inferior septum and inferior wall, RCA, left circumflex is the lateral wall. If you go to the mid-level now, okay, so mid-level is where you have the papillary muscles, anterior wall, inferior wall, lateral wall, and your septum. So remember, at the basal and the mid, 6 segments or 6 regions, and you have to be able to name them, and it's basically the same thing as the basal. The LAD, the anterior wall, RCA is the inferior wall, and the left circumflex is lateral wall. At the apex, so this is the apex where you have only 4 segments. You have the anterior wall, inferior wall, lateral wall, and septum. So your anterior wall and septum is almost exclusively the LAD. Anterior wall and septum, LAD. The inferior wall is the RCA, and the lateral wall is the left circumflex. So just go over this, sort of commit it to memory, draw it a million times so you and label it so you know it. And then if you look at the parasternal long, okay, or if you call it the vertical long, then you will talk about a apical cap. So this 17, you know, when we talk about warm motion score, warm motion score index, we talk about the apical cap. But you know, you need to know this, and then if you do your apical views, you need to know the segments there and the coronary artery distribution as well. All right, so let's go over the stress test. So the reason for doing a stress echo is to diagnose coronary artery disease. We want to see if the patient has blockage, and if the patient has blockage, you know, you can get an assessment of how significant the blockages are. We usually use the fact that, you know, the resting echo may be normal. So the resting echo may be normal, but if we stress the patient, we can bring out the warm motion abnormality. So when we do a stress echo, we hook the patient up to our ECG system and say we're doing, let's use a treadmill stress echo as an example. So we'll hook the patient up. You want to get a resting 12 dBkg, because if the patient is having a heart attack right there, you don't want to do it. If the patient is having, say, if the patient is in atrial fibrillation and the heart rate is 150 beats per minute, it doesn't make any sense to do it. If the patient is having ventricular tachycardia, you don't want to do it. So there are some situations that when you look at the ECG, you don't want to do the stress test. So you always get a resting 12 dBkg and look at that. you have to get baseline or resting blood pressure. And it's good to talk to the patient, make sure the patient is not having any significant chest pains or significant shortness of breath before you do the test. So you're going to get vital signs before, you're going to get a brief history before, and then you hook the patient up, you get your baseline or resting ECG, you put them on the treadmill, and you let them walk. So if you're using the Bruce protocol, then every 3 minutes, you increase the speed and inclination. There are different type of protocol. You can use manual protocol, you can use Bruce protocol, you can use modified Bruce, you can use Norton, and there are other protocols. Or you can just use a manual protocol. But they will test you usually on the Bruce protocol. The Bruce protocol, every 3 minutes, you increase the speed and the inclination. With the Bruce protocol, you start at a speed of 1.7 meters per second and an inclination of 10 degrees. And then you're going to the next, so that's stage 1. Stage 2 is 2.5 meters per second, inclination of 12 degrees. Stage 3, speed of 3.4 meters per second, inclination of 14. Stage 4, speed of 4.0 and an inclination of 16. And you gradually increase the speed and the inclination. Your target is to get to a certain heart rate, and that heart rate depends on the maximum heart rate for the age of that patient. The target heart rate depends on the maximum heart rate for the age of the patient. The maximum heart rate is 220 minus the patient age, and all you need to do is get 85% of that. So first you have to calculate the maximum heart rate, which is 220 minus the patient's age. And for the test to be a good test, the patient needs to achieve 85% of the maximum heart rate. So when you do all of that, okay, and the patient exercise and you achieve at least the target, but when we do a stress test, you should try and do what we call a symptom-limited stress test. What we mean by that, whatever symptom the patient was having outside, whether it's chest pains or shortness of breath, you're going to exercise the patient until the patient becomes symptomatic. Until the patient becomes symptomatic. Or at least they should achieve 85% of the maximum heart rate. Again, the maximum heart rate is 220 minus the patient's age. All they have to do is achieve 85% of that. So once you get a good treadmill test, okay, and during the stress test, you're going to ask the patient, are you having any symptoms, chest pain? But don't just stop at chest pain, because patients' perception of pain can be tightness, pressure, burning, squeezing. So you need to go over all those things with them. Find out what type of discomfort they're having. Is the discomfort getting more severe as the exercise goes on? You also need to do blood pressures periodically during the stress test. You need to do blood pressure at every stage. Okay, so usually a good rule of thumb is to get your blood pressure 2 minutes into the stage. 2 minutes into each stage. Okay? Again, you're going to talk to the patient, see if they're having any symptoms. You're going to look at the ECG, see if the ECG change. And of course, the changes that you're going to look for in the ECG, you're You're going to see if there's any arrhythmia because it's important. The patient may now move from a sinus rhythm to atrial fibrillation, ventricular tachycardia, AV blocks, so you need to look for these things. But what you're looking for specifically to tell you if the stress test is positive is ST segment deviation. ST segment deviation. And the deviation that you're more concerned, or you're most concerned about, is ST segment depression. So we talk about ST segment depression. So you're going to look at your ECG, you're going to look at the ST segment, and you're going to look and see if the ST segment is depressed. We usually talk about 3 types of ST segment depression. You can have a downsloping ST segment depression, horizontal ST segment depression, or upsloping ST segment depression. Okay, so those are things you're going to look for. When the patient finishes walking on the treadmill, you're going to turn the treadmill off sudden. So if you were just doing a stress ECG, then you let the patient gradually cool down. So with the stress ECG, the patient can gradually cool down and then walk. After you complete the maximum, they can walk for another 4-6 minutes to recover. With the stress echo, there is no recovery. You stop it sudden and you put them on the gurney, the table, and you start doing your echo. So you do an echo at rest. That's a resting echo. You want to see the wall motion. And then as soon as they finish the test, you put them on the gurney, the table, and you're going to do another echo. You want to get this echo done within 90 seconds, okay? Because that is when you're going to see the wall motion abnormality. So you have about 90 seconds to do it, so it is a quick maneuver. So again, you do your echo at rest, okay? You want to look at wall motion, and you want to overall assess ejection fraction. And then when you exercise the patient, you stop the treadmill suddenly, and you bring them under the bed, and then you repeat your echoes. Again, you're looking for wall motion abnormality and the ejection fraction, okay? You're also looking for chamber size because sometimes the LV chamber can dilate, okay? So you have to be able to interpret the results. So when you do your stress echo, if you're resting to the echo, all the walls are normal. There's no wall motion abnormality, and you do your stress test. Okay, say this ejection fraction was 55% at rest, no wall motion abnormality. You exercise the patient now. The ejection fraction is 70-75%. All the walls are moving very well, thickening very well. This is normal. This is what a normal person should do. A normal person is going to have no wall motion abnormality at rest. Ejection fraction is going to be normal. But when you exercise them, the wall's going to move more rapidly. You're going to get increase in the ejection fraction. Okay? The cavity, the LV cavity should be less. So this is a normal patient. Ejection fraction should increase by more than 5% with exercise. So if this is 60-65%, this should be at least 70-75% or more with exercise. So this is your normal patient. Normal resting echo, hyperdynamic with stress, normal. As opposed to this patient who have normal walls. At rest, the walls are normal. when you exercise the patient, there is some more motion abnormality, wherever it is. This is what we call ischemia. Okay? So at rest, the heart muscle doesn't require that much blood flow, so everything looks normal. But once you exercise the patient and the heart muscle now requires more blood flow and you cannot deliver, then that muscle is not going to move very well. And that's what we call ischemia. You get warm motion abnormality with stress. You can also have another scenario where there is warm motion abnormality at rest. So there's an area that's, say, hypokinetic, and then when you exercise the patient, it becomes akinetic. So it wasn't thickening very well at rest, but now it's not thickening at all with stress. That's also ischemia. Okay? That's also due to blockage of blood flow. Another scenario is warm motion abnormality at rest. So you do your resting to the echocardiogram and you have warm motion abnormality. You stress the patient, you do your stress echo, and there's no change. That's because the muscle is infarcted. Well, we said the muscle is dead. So dead muscle not gonna move. So it looks abnormal at rest. When you exercise the patient, it looks the same because dead muscle not gonna move, are not gonna thicken. Dead muscle doesn't thicken, so that's an infarction. Or if it's akinetic, so it's not thickening at all, you exercise the patient and it becomes dyskinetic, okay? Then it's also an infarcted muscle. So when you do a dobutamine stress echo, the beauty of a dobutamine stress echo is you can determine what we call viability. So we do a dobutamine stress echo if the patient cannot exercise for whatever reason. If the patient has, say, problem with the lower extremity, amputation, spinal stenosis, they can't walk for whatever reason, you can do a chemical stress echo, and that's a dobutamine. Dobutamine is probably the most common chemical stress echo. You have other things such as adenosine and stuff, but it's not commonly done. The dobutamine is the more common chemical stress echo. When we do our dobutamine stress echo, we do the same thing. We do resting echo. You get your echo at rest, and you're gonna infuse your dobutamine. So you're gonna give dobutamine, and we usually talk about micrograms per kilogram per minute. And just like your Bruce protocol, every 3 minutes, you're gonna give more dobutamine. So we usually talk about a low dose dobutamine, and the low dose dobutamine is between 5 and 10 mics. Okay? So micrograms per kilogram per minute. So either you infuse it in or you can push it. And then stage 2, you increase your dobutamine. So stage 1 is 5 mics, stage 2 is 10 mics, stage 3, 20, stage 4, 30, stage 5, 40. So most protocol will go up to 40 or 50 micrograms per kilogram. Okay, so most dobutamine protocols will go 40 or 50 micrograms per kilogram per minute, not more than that. And you're looking for the same thing. You want to see 85% of the maximum heart rate response. So the maximum heart rate is 220 minus the patient's age. patient have to achieve is 85% of that. Okay? With the dobutamine, you're going to do an echo at rest. You're going to do an echo at low dose. And as I mentioned before, the low dose is between 5 and 10 micrograms per kilogram per minute infusion. You're going to pump that amount of dobutamine in the patient. So before the 10 micrograms per kilogram per minute infusion, you're going to get another echo. So one at rest, one with low dose, then you're going to get another echo at the peak of the dobutamine infusion when the patient's heart rate is at target. You're going to get another echo. If you have difficulty getting the patient to target heart rate, you can use atropine. Atropine is a medication that can speed up the heart rate. So you can give atropine, you inject atropine to increase the heart rate to get to target. And then once you get to target, you're going to do what we call your peak echo, peak dobutamine echo. And then 10 minutes after the peak, you're going to get a recovery. You're going to get a recovery echo. So with the dobutamine stress echo, you're going to get 4 images. 4 images. You're going to get resting, low dose, peak, and recovery. Okay? And you're going to compare all of them. The reason why we do so many images in the dobutamine is because we can use our dobutamine stress echo to determine viability. And when we talk about viability, it's essentially the same thing as it sounds. Viability. We're looking for viable muscle. Because when you see a patient with, say the patient comes to the echo lab and they have an ejection fraction of, say, 30%. So ejection fraction of 30%, you know that probably some of the heart muscle is dead, or it's not dead, but because it's having decreased blood flow, it's sort of hibernating, okay? It's sort of conserving its energy because it's not getting sufficient nourishment. But if you were to, say, increase the blood flow to the muscle, so you send the patient to surgery. You send the patient to surgery and they do surgery to increase the blood flow to the heart muscle. Because the heart muscle is not dead, then it starts to contract normal. Okay? So we can use the dobutamine echo to determine if someone with, say, a low ejection fraction or wall motion abnormality, if some of that muscle is alive and viable, all it needs is increased blood flow. So what we do with the dobutamine stress echo, if they have, say, an ejection fraction of 30% at rest, and with the low dose dobutamine, that ejection fraction goes up to 50%. And then at peak dobutamine, it probably fall back down to 30%. At recovery, it might be 30%. The reason why the ejection fraction increase with the low dose dobutamine is because there is viable muscle there. Because remember, dead muscle not going to contract. So the reason why the ejection fraction increase, or if you look at the muscle, and the muscle is now thickening a little bit more, the reason why it's doing that is because you have viable living muscle inside that area. That's the only reason why it's going to increase thickening or increase ejection fraction. And that is what we call the biphasic response. So if you do a dobutamine stress echo and there's wall motion abnormality at rest, say ejection fraction 30%, you give your low dose dobutamine, and the ejection fraction now increased to 50%, but at peak, it falls back down to the 30%. It suggests that there's viable muscle, living muscle in that area. So when they talk about wall motion abnormality at rest and a biphasic response, you can only do this with dobutamine, and a biphasic response with stress, it suggests viable muscle. So that's going to be a question in a lot of you guys' exams. Okay, so biphasic response with dobutamine suggests viable muscle. Okay, we'll go over dobutamine stress echo again, but when you get the biphasic response with dobutamine, it suggests viable muscle. If you do your echo at rest and say the ejection fraction is, so this is a stress echo now. You do your stress echo and the ejection fraction, say 30%, and then you exercise the patient and the ejection fraction goes up to 50%. That suggests a cardiomyopathy. So remember, with a cardiomyopathy, with a non-ischemic cardiomyopathy, the heart muscle is weak, and the heart muscle is weak for a number of reasons. Okay? But when you exercise the patient, because there is no blockage of the blood vessels around the heart muscle, it can increase in its contractility. So this is different from your dobutamine stress echo. And the reason why we call it a biphasic response is because with low dose, the ejection fraction will go up, but with the peak dobutamine, it's going to go back down. So it's a biphasic response. So you have to know this chart. You have to go over this chart. You have to write the chart out using these two scenarios and then do the interpretation, because that's what they're going to put on the exam. They're going to give you the rest, the stress, and ask you how you're going to interpret the results. Okay? All right. I don't know if that's too much for you guys so far. Do you want us to continue or leave the rest for a later date?